Well, welcome back to part two of chapter 35, where we were talking about head and spinal trauma. We'll pick up right where we left off. We'd finished up with the bulk of the primary survey, and we're rolling right into history taking. So it's important to note, though, when you're assessing the patient's when you're taking a history from a patient, you really need to assess whether or not the history or their ability to present the information to you is reliable. And you want to consider them unreliable, at least to some degree, if they're having an acute stress reaction, maybe if they've got a distracting injury or even an altered mental status from a brain injury or some form of intoxication. Unreliable patients need to still have that continuous spinal protection until an appropriate, radiographic evaluation can rule out the fact that there's not any injuries, just quite simply because they're not able to provide you with the good and reliable information. You should always maintain a high index of suspicion and treat all patients with major trauma above the clavicle or who are found unresponsive as if they have a spinal injury. When you can, get a good sample history, noting the circumstances of the incident, including the forces the patient was subjected to, and if the trauma was blunt or penetrating. Ask about any flexation or torsion types of injuries to the neck that may have occurred. And in the case of a fall, ask about the height, if they struck any objects on the way down, how they landed, what parts of the body hit first, and what kind of surface that they actually landed on. In a vehicular crash, ask about the use and the positioning of any restraints that were used, where the patient was positioned in the vehicle, the degree of damage to the vehicle and the location of where that damage is, and the time that this initially occurred, how much time has lapsed between the incident and where we are right now. And then, last but not least, ask about any changes in the patient's condition. Have they gotten better since the accident? Are they, speaking more clearly, regained consciousness, or have they gotten worse? If there's any kind of changes, those are all noteworthy. And then moving on into the secondary assessment, when we're doing a secondary assessment on a patient with that suspected spinal injury, we're going to have to adjust that physical exam based on not only their level of consciousness, their ability, their reliability as a historian, but most importantly, based on the mechanism of injury and where we might suspect to find those injuries. We're going to make some adaptations and some adjustments based on that so we don't further injure any potential spinal injuries that they may have. If the patient has a high or an intermediate mechanism of injury and hasn't already been mobilized by this point, complete your physical exam with the patient in a neutral position without moving the spine. To do this, of course, you should first apply manual stabilization. If that patient is combative, you may need to administer some form of sedative or perform even a rapid sequence intubation procedure. Of course, this is going to also depend on their ability to protect their own airway as well. You should thoroughly assess the head and face for soft tissue injuries, bony instability, and any kinds of depressions or abnormal features. Also look for drainage from the ears and nose, battle signs behind the ears, and periorbital ecchymosis, also known as raccoon eyes, for bruising underneath the eyes. Realize, though, that these signs, battle signs and periorbital ecchymosis, may not show up for some time after the initial insult, but sometimes it can show up a little bit quicker than you think. If the cervical collar is not yet placed, reevaluate the head and face for injuries. You should frequently check the patient's pupils for size, shape, equality, and reactivity. And when assessing the pupils, check both the direct and consequential response to light. A sluggish pupil is an early sign of increased intracranial pressure and also could indicate cerebral hypoxia. Unequal or bilaterally fixed and dilated pupils are a later sign of increased intracranial pressure, and they indicate pressure on one or both oculomotor nerves and potential herniation. If the patient's alert, evaluate the extraocular movements and look for any nystagmus. You should also evaluate the pupil's ability to accommodate focal length changes. And finally, evaluate the chest and abdomen for both internal and external injuries. You should monitor the cardiovascular system for signs of shock. In male patients, assess the urethral opening for any signs of blood, as well as for scrotal swelling, ecchymosis, and even signs of a priapism. You should also look for abnormal posturing. For patients with altered sensation, you need to obtain a blood glucose level as well. You can get a specific number for intracranial pressure in the field. You can't get a specific number for the amount of intracranial pressure in the field, but you can estimate how severe the increase is. Your critical treatment decisions will be based upon key findings like posturing, hypotension, hypertension, and abnormal pupil sizes. You should use the serial Glasgow coma scores and pupillary assessments to monitor for any progression in the patient's state of intracranial pressure. The neurological exam is intended to establish a baseline for later comparison and determine if you need to immobilize the patient. You should begin by determining the patient's baseline level of consciousness. Myotomes are regions where the motor components of the spinal nerve supply specific tissues and muscles. You should examine the patient from head to toe, starting with cranial nerves. Assess each major motor group from the top down to identify the lowest spinal segment that has normal voluntary motor function. As you do this, you're going to ask the patient to flex their elbows and then extend them, followed by their wrists. Spread and then bring their fingers together against resistance. As an alternative, you can ask them to curl their fingers while you apply some resistance. Bend and extend their knees, plantar flex of their feet and ankles, dorsal flex their toes to gravity and against resistance. In an unresponsive patient, of course, motor function can be assessed by their response to a painful stimuli, but you're not going to be able to assess the more fine motor movements. Ask the patient to squeeze your fingers to assess their grip strength. Have the patient extend their arms with their palms up to check for pronator drift. To check for arm drift, have the patient extend their arms with their palms up and then close their eyes. Have the patient flex their foot towards their body, dorsal flexion, and then press down with their foot, plantar flexion against resistance. To check the patient's lower extremities, have them push their legs against your hands while their knees are slightly bent. Have the patient extend their legs straight out against some resistance. To check the patient's feet, have them pull their feet up towards their body and then push down, with both of these against a little bit of resistance so you can see what the motor strength is. Of course, dermatomes are another area we can look at, and these are regions where the sensory components of the spinal nerves supply specific areas of the body's surface. You should test for any general loss of sensation and ask about abnormal sensations like pins and needles, electric shocks, or a hypersensitivity to touch that they may be feeling. Assess the patient's sensory integrity on both sides of the body, starting from the feet and working your way up. Your goal is to identify the lowest level of normal sensation and assess the patient's perception of light touch, temperature, and position. Reflexes can also give you valuable information about sensory input. In significant spinal cord injuries, reflexes are usually absent but may return several hours or weeks later. If the patient's reflexes are intact, it's likely that their motor and sensory activities have been preserved. A positive Babinski's reflex happens when the toes move upward in response to a stimulus on the sole of the feet, and this is usually an indication of a spinal injury. For an unstable patient, you should monitor their vital signs every 5 minutes. For a stable patient, you can monitor them about every 15 minutes, but you always want to be on the lookout for hypotension. Even if there are no signs of shock present, you want to be keeping alert for that beginning to develop. You should check all of your interventions to make sure they're still being effective and working like they're intended. Repeat the physical exam and reprioritize the patient's care as needed based on those findings. Be sure to document any suspected spinal injury, noting the area involved, any sensation, dermatome issues, motor functions, and any other areas of weakness that you discover along the way. All right, so how frequent is head trauma? How often does head trauma occur? Well, when we look at head trauma, we're talking about both head injuries and traumatic brain injuries, so the noggin and inside the noggin both. According to the Centers for Disease Control and Prevention, traumatic brain injuries contributed to almost 61,000 deaths in the United States in 2019 alone. So that's an annual number that's going to be roughly about the same from year to year. The most common cause of traumatic brain injuries are falls. And then we have firearm-related injuries, motor vehicle crashes, and assaults. Groups that are at higher risk of sustaining traumatic brain injuries, dying from one, or having long-term health problems after the injury include racial and ethnic minorities, those that are military service members and veterans, people experiencing homelessness, those that are in correctional or detention facilities, survivors of intimate partner violence, and people living in rural areas. Closed head injuries are the most common type and are caused by blunt trauma. In a closed head injury, the dura mater is undamaged and the brain tissue is not exposed to the outside. These injuries can result in skull fractures as well as traumatic brain injuries. They may be either focal, meaning they are limited to one specific area of the brain, or diffuse, where they may be much more spread out and are much more complicated by increased intracranial pressure. Open head injuries are associated with some sort of penetrating mechanism. In these cases, the dura mater is penetrated and the brain tissue is exposed to the outside environment. So, how do we manage these? How do we deal with these head injuries? Of course, scalp injuries, as you guys know, range from minor injuries to serious lacerations and avulsions. But even a small laceration can lead to a whole lot of bleeding because the scalp is so vascularly rich. So don't let the bleeding distract you from the risk of more serious underlying injuries. In adults, hypovolemic shock is rarely caused by scalp lacerations alone, so you should look for other possible causes of blood loss if you're suspecting your patient is shocky. Scalp lacerations often suggest that there may be a deeper, more serious injury underneath that. When assessing a scalp injury, consider the mechanism and inspect the area for any missing tissue, impaled objects, or residual contaminants. Evaluate the patient often for signs of continued bleeding. But for those isolated lacerations, your goal is going to be to stop the bleeding. You can apply direct pressure for minor to moderate lacerations, while pressure dressings and hemostatic agents may be needed for more significant lacerations. If you have time and there are no other injuries to manage, a quick rinse can help reduce the chance of infection as well. You should not explore the injury because this can disrupt the clot that has already formed and can start the bleeding all over again. The significance of a skull fracture is related to the type of fracture, the amount of force that was applied, and the area of the head that has sustained the fracture. Potential complications are going to include intracranial hemorrhages, cerebral damage, and cranial nerve damage. Linear skull fractures are also known as non-displaced skull fractures and make up the majority of the skull fractures that we see. Most of these fractures happen in the temporal parietal region of the skull, and they don't have any obvious physical signs that they're there. Depressed skull fractures are the result of a high-energy direct blow to a small surface area of the head with a blunt object. The frontal and parietal regions of the skull are most susceptible to this type of injury because the bones there are relatively thin. Between 75 and 90% of these fractures are also open fractures. Patients often show neurologic signs, and these fractures have the greatest association with patient death. Basal skull fractures happen when a linear fracture extends to the baseline of the skull, which can cause a tear in the dura mater. These fractures are associated with high energy trauma, but typically result from widespread impact to the head. Open skull fractures are the result of severe forces that are often associated with trauma to multiple body systems. These expose the brain tissue, and because of this, they have a much higher mortality rate. When assessing a skull fracture, use the pads of your fingers to apply gentle pressure over the entire skull, noting any swelling, edema, deformity, depressions, or crepitus, but do not palpate a depression when you notice one. Signs of a basal skull fracture include cerebral spinal fluid drainage from the ears or nose, which are going to be primary what we're going to see, and then those bruising areas like we talked about, the raccoon eyes or the battle signs behind the ears, which may not show up, as I've mentioned, for 24 hours after the injury. You should identify and treat any life threats found during the primary survey, as we normally do, and be sure to provide manual inline stabilization of the cervical spine and supportive care for linear skull fractures. If brain tissue is exposed, lightly cover it with a sterile dressing moistened with sterile saline. For any cerebral spinal fluid leakage, apply a loose sterile dressing, but try not to stop the flow. You want to let that go ahead and flow out. Any impaled objects, of course, should be stabilized in place and protected from further movement. All right, so let's look at some brain injuries. Traumatic brain injuries are classified in two types. There's a primary brain injury, which is an immediate result of the initial impact to the brain and its associated structures. So this is the injury that happens right away. And then there's the secondary. This is a consequence of the primary injury and can occur anywhere from a few minutes to several days later. Secondary brain injuries are going to include things like cerebral edema, intracranial hemorrhages, increased intracranial pressure, cerebral ischemia and hypoxia, hypoglycemia, hypotension, and even infection can fall into this category. The only way to reduce brain injuries is through preventative programs. Most brain injuries happen indirectly, but direct injuries are typically caused by penetrating objects. Motor vehicle crashes are the most common cause of brain injuries, and this is where we'll see those indirect injuries. And that we'll see something oftentimes in automobile accidents called the coup contra coup injury. This is that front and rear type of injury. In these injuries, the passenger's head hits the windshield on impact. The brain continues to move forward until it strikes the inside of the skull, and this causes a compression injury or bruising to the front part of the brain and stretching or tearing to the back part of the brain. The head then falls backwards against the headrest and the brain slams into the back of the skull. This same type of injury can occur on the opposite sides of the brain in a side-to-side impact as well. After a brain injury, the injured brain starts to swell because of the dilated cerebral vessels and the increased cerebral fluids. An increase in intracranial pressure can be caused by blood accumulated inside the skull or by the brain itself swelling. When the intracranial pressure increases, it squeezes the brain against the bony parts within the cranium. The cerebral perfusion is the difference between the mean arterial pressure and the intracranial pressure. The formula is, you can see here on your screen, the CPP equals MAP minus ICP. The mean arterial pressure is the diastolic pressure plus 1/3 of the pulse pressure. In normal intracranial pressure, 5 to 15, and normal MAP is 85 to 95. These pressures produce the normal cerebral perfusion pressure of 70 to 90 millimeters of mercury. So you can do the math. Normal intracranial pressure 5 to 15, a normal MAP 85 to 95 will get us 70 to 90 of the cerebral perfusion pressure. Any increases above 20 intracranial pressure decreases the cerebral perfusion pressure and the cerebral flow. So now, regardless of what everything else is going on, once that intracranial pressure gets above 20, we start to see decreases in brain perfusion. When this starts to happen and those intracranial pressures rise, the cerebral perfusion pressure begins to drop. The body tries to maintain that by increasing the mean arterial pressure. This is indicated by an increasing blood pressure and a widening pulse pressure. So that's why we see that triad begin to develop. Other factors that can interfere with the cerebral perfusion pressures are hypotension or swelling and bleeding. Treatment should focus on maintaining the cerebral perfusion pressure and cerebral blood flow while trying to lower the intracranial pressure, which is very, very difficult, if not impossible, to do in the field. Uncontrolled or unmanaged, we wind up with a brain that herniates. And this is when the brain is forced from the cranial vault through either the foramen magnum or the tentorium. Typically, we see it's through the foramen magnum. The lateral herniation syndrome or unical herniation is the most common type. In this syndrome, a portion of the temporal lobe or the unicus is displaced laterally and moves downward through the tentorium incertia and compresses the midbrain and the posterior cerebral arteries. Signs of herniation include dilation of the pupils on the same side of the injury and motor dysfunction on the opposite side. Central herniation occurs when the brain tissue shifts downward and completely compresses the brainstem from above. And then we have this tonsillar herniation, is when part of the cerebrum is forced through the foramen magnum, which compresses the brainstem. The brainstem compression destroys the respiratory center, which then induces apnea and decreases perfusion to the rest of the brain and ultimately leads to death. Early signs and symptoms of this increasing intracranial pressure is going to be vomiting, headache, altered level of consciousness, and maybe even seizures is not real uncommon. Later signs of this intracranial pressure include hypertension, widening pulse pressure, bradycardia, which all come together to make what's known as Cushing's triad. So those are pretty common signs. Hypertension, widening pulse pressure, and bradycardia is Cushing's triad. Realize though that this says later signs, but this doesn't necessarily mean later, like later in the hospital. These can be very commonly seen in the field with severe head injuries and rapid increases in intracranial pressure. Well, it's not uncommon for you to see this Cushing's triad. You may also see some changes in respiration, such as Cheyne-Stokes or central neurogenic respirations. Other signs, of course, are unequal and non-reactive pupils, comatose, or even posturing. When we talk about posturing, these two images on your screen kind of show them pretty well. Decorticate posturing is flexion of the arms and extension of the legs. So everything kind of flexes out, and you kind of see them by the telltale where their wrists kind of curl up outwardly. Decorticate is the one where they come into the center, so their arms kind of curl up around their chest. And decerebrate posturing is where everything kind of pushes out. So the way that I always remember those was decorticate was towards the core, towards the center of the body, and decerebrate was out. So That's typically the easiest way to remember those. There is some importance to which one that they may have in the severity of their injury, but that's for a little bit later of a discussion. Diffuse brain injuries are going to affect the entire brain. A cerebral concussion is a diffuse brain injury that's caused by direct blow to the head, face, or neck, or by an impulsive force transmitted to the head. The resultant disturbances in the brain function are related to those neurometabolic dysfunctions. The pathophysiological changes can occur after both single and multiple concussions, and less force may be needed to cause symptoms in subsequent concussions. Of course, a concussion usually resolves on its own within about 3 months, but a few individuals may experience symptoms for more than 1 year after the injury. Athletic venues are common places for these concussions to happen. Authorizing an athlete to return to play after a potential concussion is very much outside of a paramedic scope of practice. Instead, you should consult with medical control because these patients need to see a physician and have some more tests run. You should also refer the concussion action plan steps that are actually developed by the CDC Heads Up program. These steps include removing the athlete from play, making sure they're evaluated by a healthcare professional with experience in evaluating concussions, and informing the athlete's parents or guardians about a possible concussion, and providing them with some information to help them be more aware of some of the things to watch out for. The athlete should be kept out of play for the day of the injury, and only be allowed to return with permission from an experienced healthcare professional. That way we can reduce the likelihood of repeated injuries. So now what we want to do is we want to complete our primary survey and address any life-threatening conditions. The secondary assessment should be focused on evaluating for a concussion, which requires a thorough evaluation, and that focus is primarily on cognition. The patient's history is a key component of this assessment. You should ask the patient questions to assess their memory and their awareness of person, place, time, and situation. With the patient's consent, you should include people who know the patient during the assessment to help verify their answers. You can ask athletic trainers to compare your current findings to preseason findings, and ask the patient to remember a series of words or numbers and repeat them back later. The emergency treatment for a patient with an isolated concussion is primarily supportive. It involves patient education, monitoring, and transport to a proper facility with the focus on physical and mental rest. If a patient refuses transport, you should get informed refusal, and your system may require you to contact medical control in these instances. You must also give the patient specific CDC information related to concussions. It's always a good idea also to ask patients, especially athletes, about any recent concussions. Second impact syndrome is rare, and an often fatal result of receiving a second concussion while still recovering from an earlier one. During recovery, the brain is very vulnerable, and its ability to regulate itself has become disruptive. Even a minimal force can cause an increase in cerebral blood flow, brain herniation, and death, which can happen in just 2 to 5 minutes after a secondary injury. Signs and symptoms include a sudden loss of consciousness after the blow to the head, a stunned appearance, loss of eye movements, dilated pupils, respiratory failure, and even cardiac arrest. The emergency treatment is going to be completely supportive. A second concussion that occurs within 7 to 10 days of the previous concussion requires immediate transport to the nearest hospital with neurosurgical capabilities. Post-concussion syndrome is when a patient may still have signs and symptoms for several months after their initial concussion. This is different from second impact syndrome because the symptoms are a result of the original concussion and not a second impact. The patient must be transported for evaluation by a physician. A diffuse axonal injury is one of the most common types of diffuse brain injuries and has a high mortality rate. It is also the most common cause for post-traumatic unconsciousness and a persistent vegetative state after a traumatic brain injury. This injury involves the stretching, shearing, and tearing of nerve fibers and axial damage, and this damage can continue for years afterwards, leading to a progressive neurodegeneration. A diffuse axonal injury is caused by high-speed rapid acceleration deceleration forces. These injuries are classified as mild, moderate, or severe. The main finding for a diffuse axonal injury is unresponsiveness, which often lasts for more than 6 hours. The treatment for this injury is primarily supportive. Always be aware of potential airway compromise with these patients. You should perform a primary survey and address any life threats right away. If time and resources allow, perform a secondary assessment and treat any other injuries that you find. Patients should be transported to the closest hospital that has a neurologist on staff. All right, so let's look at some focal brain injuries. Focal brain injuries is a specific and visible injury to the brain. A cerebral contusion happens when the brain tissue is bruised and damaged in one specific area. These injuries usually cause more severe neurological deficits than concussions do. The frontal lobe, of course, is the most commonly affected area. Swelling of the brain can lead to increased intracranial pressure. An epidural hematoma is a buildup of blood between the skull and the dura mater. It occurs when in a very small percentage of all head injuries and almost always results from a low force blow to the head. Patients typically experience an immediate loss of consciousness, a brief lucid interval, and then another loss of consciousness. The lucid interval only occurs in about 20 to 30% of the cases. If a patient refuses transport, you must inform them of the risks. These injuries have a high survivability rate with early treatment and surgery, but if a patient loses consciousness due to increased intracranial pressure, the likelihood of mortality goes up significantly. Signs and symptoms in a conscious patient are limited to those of an associated concussion, as well as soft tissue damage or crepitus in the area of impact. That's why it's important for even concussion patients to be evaluated at the hospital, because they could have an epidural hematoma. As the intracranial pressure increases, patients will show signs and symptoms like ipsilateral pupil dilation, contralateral motor dysfunction, nausea, vomiting, seizures, urinary incontinence, visual disturbances, posturing, and in late stages, you'll start to see that Cushing's triad start to show up. A subdural hematoma, on the other hand, is a collection of blood located between the dura mater and the outside of the brain. This is the most common type of intracranial hemorrhage, and it's associated with bleeding from veins in that area. Increased intracranial pressure develops more gradually with this type of hemorrhage, and patients often have a fluctuating level of consciousness. Focal neurologic signs or slurred speech are common. Subdural hematomas are classified as acute, subacute, or chronic. Subacute cases have a much lower mortality rate. Patients with a history of brain atrophy are at a high risk for chronic subdural hematomas. A subacute or chronic subdural hematoma should be considered in any patient with a history of head trauma and signs of headache, dysphagia, hemiparesis, personality changes, visual disturbances, difficulty concentrating, nausea, vomiting, unilateral dilated pupils, posturing, new onset seizures, or vital sign changes consistent with Cushing's triad. So a whole laundry list of things, but they're all brain and cognition related. An intercerebral hematoma is a bleed that occurs directly within the brain tissue itself. It's the result of either maybe a penetrating head injury or rapid deceleration forces. Many of these hemorrhages are associated with other brain injuries, such as diffuse agnal injuries. A patient's condition with an intercerebral hematoma can deteriorate very quickly. Even with surgery, this type of injury has a high mortality rate. A subarachnoid hemorrhage is bleeding that occurs in the space between the arachnoid membrane and the brain. This type of bleeding leads to bloody cerebral spinal fluid and meningeal irritation. It is most often caused by trauma or the rupture of an aneurysm. A patient with this condition typically reports sudden headache. As the bleeding increases, signs and symptoms of increased intracranial pressure begin to develop, including decreased level of consciousness, pupil changes, posturing, vomiting, seizures, which is usually resulting in death. A subgaleal hematoma is bleeding between the periosteum and the glia. It can cause enough blood loss to lead to hypovolemia in infants. These types, a subgaleal hemorrhage is a firm nodular mass, and the phrase goose egg is an idiom used to describe it. So we've probably all had one of those in our lifetime at one point in time or another, but realize with infants it can be a serious thing. They can lose enough blood to cause hypovolemia. Okay, so there we have it, part 2 of 3 with head and spinal injuries. The next section we'll finish up just a smidgen left on head injuries, and we'll dive into the spinal stuff, and then we will be done with it. See you guys back at part 3.